All right, so now we're going to get in a little bit more detail with the heart and heart's function. We kind of briefly introduced in terms of the electrical activity. Now we're going to actually talk about the heart as a pump in terms of blood volume and its effectiveness at moving blood around. All right, so we're going to talk about cardiac output, stroke volume, and cardiac reserve. We'll talk about how we calculate this. We'll talk about things that go into that like help influence cardiac output, and then get more into stroke volume and Frank Starling law of the heart, and then talk about preload or the EDV, how that's regulated, ejection fraction, and how heart rate and cardiac output is regulated and variable amongst different organs. All right, so since like how much oxygen we need varies depending on our activity level, right? If you are more active, you need more oxygen. If you're less active, you don't need as much oxygen. The heart has to be able to variable eject this blood that has oxygen in it to meet that demand, right? And so we call this basically the blood output from the heart, the cardiac output. So the cardiac output, simply saying, is how much blood, right? The volume of blood that is pushed out of the left ventricle each minute. And if we calculate this out, we can do so by looking at the stroke volume per beat. So how much of this blood is ejected with each contraction times the heart rate, how many beats per minute, right? And if you think about it, that makes sense, right? How much blood is being ejected for each individual beat? How often is the heart beating? Those things together gives you the cardiac output. Now, on average, a person's heart rate at rest is about 70 beats per minute, although that can really range from like 55 to 90-ish, depending on your activity level and all of that. And the average stroke volume is about 70 to 80 milliliters per beat. So that means in a given minute, the average person has a cardiac output of about 5,500 milliliters per minute, right? 70 to 80 milliliters per beat, 70 beats per minute gives you that 5,500. Right? The cardiac reserve is the ratio between the maximum cardiac output and the normal cardiac output at rest, right? So like what's the difference basically between cardiac output when you're just hanging out doing nothing to cardiac output when you're really pushing yourself. And this can vary depending on a person's training, especially with cardiovascular types training. So if we look at all these people at rest, right, we're not really doing a whole lot. Our beats per minute are generally like, here we're doing like some light activity or some like light exercise where we have about 120 beats per minute. So we're above resting. We're not resting, but we see that all three individuals, the elite trained athlete, the slightly trained athlete, and the untrained athlete, they all kind of are around the same cardiac output at this lower heart rate. But as we look at how the activity level increases, right? So we're doing something more vigorous that's going to push our heart rate higher. So 140, 160, even 180, right? As we're doing that, the elite athlete has higher cardiac output. So it's going to be pumping more blood in the same amount of time, right? And remember that blood is oxygenated, so it's going to pump more blood. It's going to be more efficient at pumping more blood that contains oxygen compared to the other two, right? We see as training drops off, so does the cardiac output, right? So we see that going to the gym, exercising, right? We see the impact that those things have, and that the cardiac output goes up even for the same heart rate, right? So again, that's more blood, right? That's more oxygen making its way through, making its way around the body in the same amount of time. So what are some things that can affect all of this? So remember, cardiac output comes down to two things, heart rate and stroke volume. When we look at the heart rate side of things that can affect your heart rate include autonomic innervation, so parasympathetic versus sympathetic nervous system stuff, hormones, right? Fitness levels, right? I already mentioned before that if you are an athlete, if you're very active, right, of some sort, then your resting heart rate tends to be lower, and age, right, as well. On the stroke volume side, we have things like the size of the heart, right? Obviously, a smaller heart can only, handle a smaller volume. Fitness levels will affect this as well. Gender, contractility, duration of the contraction, the preload, and the afterload. And we're going to talk about those three we have in those boxes, the contractility, the preload, and the afterload. Those all influence stroke volume, right? And you multiply these together to get the overall cardiac output. Now, I mentioned the stroke volume and saying that contractility, preload, and afterload all affect this. Stroke volume, again, is just how much blood can that ventricle push out every time it contracts, right? So like how much blood, like the physical amount of blood that is being pushed, right, that is being ejected from the ventricle, right, when the ventricle contracts. And there's a couple things that go into it. The contractility, the preload, right, these are going to add to this. And then the afterload, right, we can divide by that. So let's define these things. So the preload, this is also called the end diastolic volume. This is how much blood is left in the ventricles at the end of diastole. So while the ventricles are at rest, right, how much blood is left in them. And this is where we're going to get into something called the Frank-Starling law of the heart, right, which and we'll talk more about that in just a second, but just to briefly introduce it, basically, preload, the greater preload means the more stretching on the cardiac muscle fibers, and the more the more stretching we have, the more blood we can fit in there, the higher the stroke volume is what we're saying. Normally, about 60% of the end diastolic volume is what gets pushed out. So about 60% of the blood in the ventricle while it's at rest gets pushed out during contraction, and that means 40% is left behind. So it's important to note we don't get 100% of the blood squeezed out of the ventricle, right? We're not 100% efficient, but we're relatively efficient, right? But how much blood gets ejected is the ejection fraction. We'll talk about that in a little bit. Contractility, this is the strength of the contraction. There are things that can affect this. So we're really just looking at electrolytes. So sodium and calcium will increase contractility. Potassium generally will decrease contractility. And then the afterload, this is the amount of pressure that the ventricle needs to exert to push blood right out during ventricular contraction. Right, so basically, like, we have to overcome the resistance coming from the other side, from the arteries, so that semilunar valve, right, that aortic semilunar valve will actually open. So we have to, as a ventricle, we have to exert more pressure than is being pushed back on us from the arteries. And so if we're looking at things that affect stroke volume, again, we're looking at these big three. Preload, this is just things that can raise preload that make it higher is going to be like a faster filling time, more blood coming back from the veins. Things that can decrease preload can be like hormonal issues, like lower thyroid hormones, right? Because then lower basal metabolic rate. Electrolyte imbalances of sodium, potassium, or calcium, low body temperature, low oxygen, pH problems, and then certain medications, right? Contractility is going to be raised by sympathetic stimulation, right? So that epinephrine, norepinephrine type stuff, higher calcium levels, higher thyroid hormones, right? Glucagon, and then lowered by the parasympathetic side, which makes sense. If sympathetic raises it, then parasympathetic, it makes sense that would lower it. And since parasympathetic uses acetylcholine, then acetylcholine would also lower it. Hypoxia and hyperkalemia, which is going to be an excess of potassium. And then afterload, this is raised due to semilunar valve damage, increased vascular resistance. This is going to lead to a decrease in stroke volume because afterload again, has a negative impact on stroke volume. So anything that increases after load will negatively impact stroke volume. And then it's lowered when vascular resistance is decreased, right? There's less pushback from the arteries, so the ventricles have an easier time ejecting blood out from the ventricle into the blood vessel. So now we get into Frank's Starling law of the heart, which basically says that the stroke volume of the left ventricle will increase as the ventricular volume, right, increases due to stretch. So basically, the more you stretch, if we think of it like a slingshot, the more you stretch, right, those muscle cells, the more volume you can fit, and the bigger the snap back, right? When contraction does happen, contraction can happen more forcefully when we stretch those muscles more. Now, of course, there is a limit, right? We see that in these pictures that in the very beginning, a little more stretch can get you a lot more in stroke volume, but it does taper out. So we can't just unlimitedly stretch these muscle fibers. There is a limit. And as we increase the stretch, we do face what we can consider like diminishing returns, that the same, like adding the same amount of stretch on top of what we already have, like as we keep doing that, we're going to get less and less and less of a gain until finally we do reach a plateau, right? So that makes sense that it's not infinite, that there is a limitation to how far the muscle cells in a heart can stretch. But generally speaking, we see that there is this positive correlation between how much the ventricle muscle cells stretch and the stroke volume that we can achieve. So again, as we increase the stretching in the myocardial cells, we increase the contraction strength, right? Again, this is because we have like that increased overlap, increased sensitivity to calcium, right? Things like norepinephrine and epinephrine can also increase contractility because more calcium becomes available, and more calcium means more muscle contraction, right? Remember calcium's role in muscle contraction. Okay, and so we can kind of see, muscle without epinephrine versus with epinephrine. We see that we get more tension, right, in comparison, right? It takes more, like a longer, basically like a length of the muscle to achieve the same tension without the epinephrine compared to epinephrine. So we see things that do have an impact on the cardiac muscle's ability to produce this force. Now, how much blood we get at the end of the diastolic of the ventricle, so like, at rest when the ventricles are not contracting, how much blood is in there. This is controlled by a couple things. One is total blood volume, right? The more blood you have, the more blood you can get back to the heart, right? So things that impact this can be urine volume, right? So how much, basically like our water-salt balance, which is closely tied to urine volume, as well as how much fluid is in the tissues, right, versus how much is getting returned to the bloodstream via the lymphatic system, right? So total blood volume will impact venous return, which venous return will then impact the end diastolic volume in those ventricles. Venous pressure, so how basically like the force that's pushing blood from the veins back towards the heart. We know that veins are under lower pressure than arteries, but they also hold more blood, right? Most of your blood is held within a vein, but they're at lower pressure. And so we have a couple things to help us with returning blood to the heart, and that can be things like sympathetic activity, right? So flight or flight, right, type stuff. As well as the skeletal and respiratory pumps, right? So remember how the skeletal and respiratory pumps, they will help us return blood through the veins up towards the heart, right, to fight gravity, using either changes in pressure from, when we look at the thoracic and abdominal cavities, that's going to be the respiratory pump, and the skeletal muscle, like let's say our calf muscle, right? The gastrocnemius or whatever, where as we are moving, as we are flexing those muscles, every time those muscles flex and they shorten and the belly of the muscle gets wider, it can push on veins, effectively squeezing blood upward, right, through the veins, through the valves. So then we get to the ejection fraction, right? So this is basically how much of the blood is leaving your heart each time it contracts, right? Because again, it's not going to be 100% effective, right? We're not removing every single drop of blood in the heart every time those ventricles contract, right? Some is going to be left behind, but we can use that percentage. We can use that understanding of how much blood is left behind and how much is effectively ejected out of the heart. We can use that to understand somebody's health in terms of heart function. So in a healthy person, we're looking at about 60% for the ejection fraction. If we're seeing less than 50%, we're seeing someone who their heart is not functioning properly, right? They have reduced function of the heart. And so if we look at the little, if we look at the equation here, right, we see the ejection fraction is going to be your stroke volume divided by your EDV, so the volume that was in the ventricle, so we break it down, stroke volume, how much blood is ejected, right, when the ventricle contracts, divided by how much blood was there, right, in that resting state, multiplied by 100. That's what we're using to calculate this out. So the stroke volume, again, how much blood is pushed out by the ventricle when the ventricle contracts, divide that by the volume of blood in the ventricles at the end of the relaxation period, so right before we can go into contraction, right? Multiply that by 100 gets you your percentage. So when it comes to our cardiac output and blood pressure, we have short-term control over this just by changing the heart rate, right? And we've seen that kind of thing before, right? When you get up from a seat or from a position of lying down, right? We notice that the heart rate goes up slightly, right? It goes up a bit to accommodate for that drop in blood pressure. So it's a good short-term, quick adjustment we can make. We can just increase or decrease the heart rate for those short-term, quick type of adjustments we need to make to maintain things like blood pressure, to maintain things like homeostasis. So what things can help regulate us here? One is autonomic, right? We have the medulla oblongata, which serves as like our kind of cardiovascular center. It's kind of handling the basics of maintaining things like heart rate. This is in addition to things like the hypothalamus with maintaining blood volume, but right now we're just focused on autonomic, which means medulla oblongata. So the sympathetic side, right, if we have sympathetic activation, this will increase the heart rate and increase the force of contraction, whereas parasympathetic decreases heart rate, which that makes sense. We've talked about that before, right? And so some of this should feel at least somewhat familiar, right? Because we've talked about this when we talked about sympathetic versus parasympathetic, when we talked about fight or flight versus rest and digest. There are other things that can regulate the heart, including epinephrine and norepinephrine, which again are related to the sympathetic side of the nervous system, but also thyroid hormones that will increase your metabolic rate, right? We see that as thyroid hormones like thyroxine, like T3 and T4, as those increase, the basal metabolic rate also increases, which also increases heart rate. Certain ions, so we mentioned sodium and calcium having a positive effect on heart rate, so increasing heart rate, whereas potassium would lower it. Again, other things that influence heart rate, age, gender, physical fitness, temperature, right? Those are things that can change it as well. So if we take a peek over here and we look at this little picture, we see that we have the control. This is just normal circumstances. We see the pacemaker potential. So again, we see that, remember that slight climb, and then we can basically depolarize ourselves, right? We get to that threshold and we can go through depolarization. And so we see that the rate that that's happening under the control. We see that with the sympathetic nerve effect. So we have the sympathetic innervation kicking in. We see that we can climb to that threshold much faster, which means we can beat more often. and parasympathetic has the opposite effect. Now, cardiac output to different organs is distributed unequally because there's differences in resistance to blood flow throughout the organs. So, depending on the organ, we may see an increased resistance or a decreased resistance. Generally speaking, decreased resistance means that we see more blood. And so if we take a look at this table here, we just see some of those differences. So GI tract and liver get a lot of blood, same with the kidneys and skeletal muscles, whereas things like the brain, the heart, the skin, and other organs are much lower in terms of how many milliliters of blood they receive per minute, right, in comparison. We also see a percentage of this, so how much of the blood is flowing through, compared to the total.